Right. So we are now recording, and I'm going to got quite a few joining right now. Well, welcome everyone. I'm still seeing some folks joining us, and we'll get started. I'll just go ahead and do a reminder to ask everyone to mute as they join. All right, we may still have a few folks join us as we get started, but I know we have a lot of information to cover. So I'm going to go ahead and get the ball rolling. So good afternoon, and thanks for joining us today for the long-term care antimicrobial stewardship. I'm Loretta Fitzgerald with KFMC Health Improvement Partners, and I'm really excited to kick off the series today with you all. Today's presentation is focused on initiatives for the prevention and treatment of UTIs and improved awareness of sexually transmitted infection risks. So I promise not to hold you up for too long from Dr. Wark, but just because I know she has a lot of great information to share with us. But before we get started, I do need to remind you of just a few things. If you're seeking CNEs, make sure that you stay on for the entirety of the program, and then also complete that program evaluation form. The program evaluation form will pop up at the end of today's webinar, as long as everything goes as planned. Certificates of attendance and CNE will be emailed out via email afterwards. And then also we are recording today's presentation and encourage you to share it with your colleagues. But please note that CNEs will only be available for those attending the live session. If you have any questions, please reach out to me, and there will be a few polling questions throughout the presentation, but also feel free to ask questions in the chat anytime throughout the presentation. All right, so now to introduce our presenter, Dr. Kelly Wark is an assistant professor of infectious disease at the University of Kansas Medical Center, as well as the subject matter expert of antibiotic stewardship and healthcare associated infections and antimicrobial resistance in the Kansas Department of Health and Environment HAIAR section. At KDHE, she is the Antimicrobial Stewardship Co-Lead, and at KU, she serves on the Antibiotic Stewardship Program and is co-chair of the Vaccine and Ambulatory Subcommittee Task Force Group. So welcome, Dr. Wark.
Thank you, and thanks for having me. Excited to do these sessions that are kind of focused more for the long-term care setting for really common infections and subsequent reasons for antibiotics in these settings. Next slide, please.
Did that advance on your end?
Yes, it did.
Perfect.
Let me know, Loretta. It probably was just at the very beginning, but if I break it out, let me know, and I'll just shut my my camera off so that if there's any bandwidth issues or anything. So today, objective-wise, we're going to go over kind of just some background epidemiology on UTIs and CODIs, and also asymptomatic bacteria, identifying kind of the most higher risk populations that have these conditions. We're going to talk about some prevention strategies. And then also, I'm not going to spend a huge time on it, but I do actually have some treatment guidelines that can be adapted to your facility based on your local resistance rates or your antibiograms. Going to talk finally, actually, maybe quite a bit about some diagnostic pitfalls surrounding UTIs and urinary dipsticks versus urinalysis and cultures. And then kind of about the latter, I'm going to say quarter or third of the session, we're actually going to change gears a little bit and talk about sexually transmitted infections. Since this is an increasing infection that's being seen in the long-term care setting. So I just kind of want to go over some of those trends, and then also some of the symptoms and treatment for that. Next slide, please. So first, when we get into asymptomatic bacteria, we're going to start off with a poll question. So which population has the greatest proportion of asymptomatic bacteria? Is this diabetic females, men in long-term care facilities, patients that perform clean intermittent catheterization, or is it patients with indwelling long-term urinary catheters? And I'll let you tell me whenever you're ready, Loretta, to end that.
Looks like things are starting to slow down, but we still have some folks answering. Okay, I'm going to go ahead and end the poll.
So all these populations definitely have higher rates of asymptomatic bacteria, but the ones that have the highest are the indwelling catheter. So that's where about 2/3 of people got that correct. Next slide.
Oh, I better stop sharing.
So asymptomatic bacteria, very simply bacteria in the urine, but no symptoms. So this is very common in many populations. Most populations most populations we don't need to screen. The two populations where we really do focus on screening for this is in pregnant females, and then if someone's about to undergo some urologic procedure. So if they're about to undergo a prostate biopsy, or they're going to have some stones, some lithotripsy for some kidney stones, something like that. That is a situation where we would screen. But everyone else, it's not really recommended that we should need to get routine urinalysis. This includes, even people that are immunocompromised, if they have neutropenia, people that have had transplants, and definitely not people with indwelling catheters, because as we'll go through here in a bit, that population is just most certainly going to have bacteria in that catheter specimen. And also, elderly that are having falls, or if there's abrupt confusion, it's important to rule out alternative causes first before kind of broadly getting urinalysis on all those populations. Next slide. So this is out of the IDSA guidelines. You can see all these kind of populations where the prevalence of asymptomatic bacteria. So I'll see a lot of people in clinic that continue to get urinalysis and cultures, and they have bacteria and they don't know why. And I think it's helpful to point out, this is kind of what I say. I say, there's a good chance if I get a urine sample right now, I'm going to have bacteria. I don't have symptoms, and this is just a common situation. And that seems pretty reassuring for a lot of people to kind of pull it back towards yourself. But you get into some of these populations. So you'll see here diabetic women, up to almost a quarter of people, they can have bacteria. Diabetic men, also very common. People on dialysis, you think they're not making urine, but then they still have a little bit of urine and then it's sitting there. So that population also, they can have high rates of asymptomatic bacteria. But you can see here in the red, the populations that have the highest rates are people in long-term care, people that are have any kind of catheter, whether that's something they're doing like a self catheter, an intermittent catheterization, or it's something that's sitting in there. Those really are going to be your populations that they have so much bacteria. And as we'll go through day by day, that rate goes up. Next slide, please. So when we talk about UTI and this terminology of like cystitis, so cystitis, all that really means is it's a syndrome of something. So you're going to have symptoms of burning, maybe you're going to have frequency, you're going to have the urge to go. Some people might have some kind of pelvic or suprapubic pain. If you start to have people that are saying that they're having like back pain or flank pain and fevers, that's a little severe for most UTIs. So if in those situations, you might want to start thinking more kidney. But it's just but this is just a constellation of symptoms. So it could be inflammation caused by infection, but it could be inflammation caused by many other things. They could have stones that can cause those similar symptoms. They could have, recently had a procedure or instrumentation or even a catheter that can cause inflammation. Some people have interstitial cystitis and they chronically have these symptoms, but it doesn't mean that their cystitis was because of infection. Next slide, please. That's a sad bladder, by the way. It's crying and has a band-aid on it. I really like that. That eye stock. I've really reused that a lot lately. So yeah, so looking at these symptoms, we think about UTI, you're going to have this kind of constellation of urgency, burning, maybe you might have some blood or frequency, but think about some other causes too. So certainly, especially as people get older, women especially, where they can have some vaginal dryness, and that is irritating when they kind of urinate. And so that could be mimicking it. As I mentioned, this condition of interstitial cystitis, which is not uncommon, stones, and then also like things like pelvic floor dysfunction, overactive bladder, and also just thinking, as we'll talk about here in a bit, sexually transmitted infections too, where you can have some burning and pain. As I mentioned, you get into the back pain, and if you're having fevers, definitely start thinking more kidney. So think about the pyelonephritis, but other things too can cause those symptoms of fever and back pain. So you could have a kidney stone that's obstructing it, and that's going to cause a lot of pain. It can cause fevers, so kidney stones, or even stuff like infarcts in the kidney. So it's not universally infection if you have all these symptoms. But what we see a lot is people get urinalysis and culture is because of smelly urine. So just remember, there are so many things that can cause the urine to smell. Certainly UTI can be one if you're having some of the other symptoms, but all these things in this column are potential culprits of why the urine might smell. So notoriously, we know about like Brussels sprouts or asparagus that can make your urine smell really gross. But other things like onions, garlic, coffee, people with liver disorder too, they can, maybe it's not such a it'll be more like a heavy and ammonia smell. And then you think of also dehydration can make this urine smell different. People with diabetes, their urine can have a more of a sweet smell, and so could people if they had like a yeast infection, it could smell a little bit sweeter. So there might be alternative reasons why they're having this a change in their smell, their urine. Also medications, these very commonly can alter what our normal urine might smell like. So we think of like sulfa meds, some diabetic meds, some of the meds that are treating immunocompromising, such like rheumatoid arthritis type meds. All these things could alter the smell. So I would advocate to not get your analysis just if it's based on the smell. They really probably should be having other symptoms um, accompanied by that. Next slide. So if so risk factors for UTIs, so certainly so sex, so that is altering the vaginal flora, but also there might be bacteria that are starting to move up from the urethra, so moving from the urethra to the bladder. Also things like diaphragms where it might block the urine, and so that can kind of lead to some stagnation and increase the risk. Spermicides, estrogen deficiency. So we're losing our good bacteria because we don't have as much estrogen. So we're losing that lactobacillus that really does protect us from other bacteria from entering. Uncircumcised males also is a risk factors. Stones, you can get those stones that then start to have a bacteria that colonize them. And so you can just get repeated infections over and over until that stone's gone. Pregnancy also is a risk factor. And so that is one of those populations where we talked about you will screen for a urinalysis, even if they're not having symptoms. And then, of course, just, diabetes is a risk factor, incontinence, people, and then of course people that are catheterizing are these are all risk factors increasing for their risk of infection. Next slide, please. So you can see here, also I pulled this kind of, you can see the citation there, but this is kind of a combination of symptoms. So you can see here the typical symptoms that we think about with a UTI is like burning, urgency. They're not very predictive of whether that person actually has a UTI. What you really need to combine it with is the urinalysis. So when you get to all those kind of symptoms by themselves, they don't really predict if there's an infection present. But when you combine those symptoms with, say, a urinalysis nitrate, you can then see that your odds ratio is getting into like 5.5. So that is really, really making you more think that they really do have an infection. And then if you see the symptoms plus the urinalysis, nitrates and white blood cells, that's that has the highest likelihood of truly having a UTI. Next slide, please. So this is kind of just kind of a graph talking about like the dipstick versus the urinalysis. And for some reason, this kind of blocked out on my other screen before when I was doing it. But basically what this is so you have the dipstick. We all know that just kind of that reagent strip that you dip into the urine. And so it is rapid, it is cheap, but you have some problems in that it doesn't give you as much details as the urinalysis. So you can get that it might answer that there's a nitrate positive or there is leukocyte esterase, but you're not getting that more descriptive details about saying, how much white blood cells is there. It'll just be something that says like +3 versus when you look at the urinalysis, it'll really tell you packed, or it'll tell you, over 50 or 20 to 50 or whatever. And then you can use the urinalysis to reflex into that culture, which really has provides so much more details. It'll provide you details about the blood, the type of the content, the clarity, the pH. All these things are just a little bit more in detail on the urinalysis. Next slide, please. There you can see the rest of the thing. I don't know why it does that. It happened on a different PowerPoint. So these are some of the limitations of the dipstick. So you'll on this you might get nitrates. That's not a great predictor of UTI. So it is when it's combined with symptoms, as we had on the prior slides. But really, by themselves, the nitrates or the leukocyte esterate, it's not going to tell you a lot, because what this is the leukocyte esterase, for example, is a breakdown product of those white blood cells. So it might be an indicator that you have white blood cells, but beyond that, it's not going to tell you much about UTI. That's where the micro for that urinalysis is so much more helpful. And then also we see a lot of positive nitrites. What that is that it comes from gram-negative bacteria. So it depends on what type of bacteria you might have for a UTI. So you can get that where if you're having certain infections with, say, a gram-positive, you're not going to have a nitrate. And then you can also see here, I put some examples of false negatives and false positives. So there's a lot of things that can interact with that. So that's really when I look at the urine, I really mainly just look at the urinalysis and focus on the amount of white blood cells. Next slide, please. So this is from Public Health Ontario. So up in Canada, they actually have, if you want to know more about like urine dipsticks versus urinalysis and the pros and cons, they have this basically like a urinary tract program, and they focus a lot on the pitfalls around dipsticks. And so I put the links here if you want to check those out, but they actually have this great toolkit. It goes about how to develop like this program for nursing home, a long-term care setting. Really could be any place, acute care, outpatient too. But a lot of this is focusing on reducing those unnecessary urine tests, really only focusing on the symptoms. And then when you have symptoms, getting the urinalysis that is a little bit more helpful. Next slide. So moving into the catheter-associated UTIs. So as many of you in this setting, you know all too well, the surveillance criteria, the definition is defined as a catheter that's been in place 2 or more days with symptoms of infection, and a culture that not has over 100,000 colony-forming units, but not more than 2 organisms. So when you get into 3 organisms, that's not meeting definition, because those would be reflecting, colony. If you have an infection, you generally have 1 bacteria, not 3. That's probably because it's coming from a catheter and it's colonization. So there's 2 big ways that you can get those catheter-associated infections. The most common way that the bacteria enter there is from the extraluminal space. So about 2/3 of cases come from that. And so that's when it's either inserted or after it's been in for a while. And then you start to have ascension of the bacteria through the capillary action. But you can also have it come intraluminally, and so this might happen from a break in that system, or the bag might get contaminated. We see a lot of the bags that'll be sitting like above the people, and so then it can go back towards that way. Next slide. So another cool question. So true or false, by day 30 of an indwelling catheter, nearly all are colonized with bacteria. So we're talking 30 days of a catheter, is that nearly all of those would be colonized? Is that true or false?
All right, it looks like the responses are slowing down a bit, so I'm going to go ahead and close the poll.
And indeed, the majority of you, about 70%, said true, and that is true. We'll go through this in the next slide if you want to move it on, Loretta.
Yeah. Okay.
So here's my little graphics. I started doing all these graphics because I was told I was using too much iStock photos. So now this is Kelly's BioRender graphic that I'm making. But anyway, so by day 330 of the catheter, you get about, on average, every day, about 3 to 10% of bacteria starting to get in that catheter. So by day 30, nearly all of the catheters are going to be, it would be universal that it should be colonized in general. But you can also not just get bacteria, you can start to getting yeast in there too. And so by about a month of having a catheter in place, anywhere, pretty broad ranges here based on the literature, but anywhere from 3% up to about 1/3 of those catheter frequently going to have just yeast sitting in there too. But the bulk of these people that have all these bacteria, this yeast sitting in the catheter, are not having symptoms. Next slide. And poll question number 3. So long-term use of indwelling urinary catheters or Foley's are associated with which of the following? So are they associated with urinary and kidney stones forming, urinary tract infections, incontinence, bladder cancer, all of the above?
Still having some good participation. We'll give it a few more seconds. Okay, I'm going to go ahead and close the poll.
So yeah, we hear so much about UTIs or CODIs as a consequence of catheters, but really they can cause a lot more than infections. We'll go on this the next slide if you want to progress, Loretta.
Okay.
So another Kelly graphic. So these blue things were stones. So that's notoriously, you can start getting increased stone formation. And I think we've seen a lot of elderly, they just continue to have problems with stones, and then they have to go undergo these lithotripsies, whether it's related to the catheter itself or because they're starting to get bacteria. Some certain types of bacteria, like Proteus, for example, where they can be more stone, more prone to forming stones. But also you can get other things as a result of that catheter in the urethra. So you can get fistulas. It's actually been having long-term catheters there has been a link to bladder cancer, but also just because they lose the normal ability to for their bladder and their muscles, their detrusor muscles, they can start being more prone. They definitely will be more prone to incontinence. Next slide. And so when we think about, like when we put catheters in, very frequent causes retention. So they're holding that urine into their bladder, but thinking about what are the reasons that they might be retaining that urine. And so these are for the really big reasons. So certainly you could have infections. They might be retaining urine because they are having, or they might be retaining their urine because they have an infection, but also think about some of the things like meds. So very common cause of retaining urine because a lot of these meds will affect the muscles that are in the bladder. And so very common meds like opioids, tramadol, Haldol, other antipsychotics, antidepressants. So very, very many of these meds, and very frequently in our population, that they're on these. Also things like neurologic. So if someone had a spinal cord injury or multiple sclerosis, cerebral palsy, all these things can impact because their innervation from their lower spine is impacting that. And then also thinking about obstruction. So people where they get enlarged prostates or BPH, other things like even cancers or adjacent cancers, prostate cancers. You can sometimes even get bladder stones that start to kind of obstruct the ureters or kind of sit at the bottom of their bladder and can cause obstruction too. And then even fecal impaction can be a cause of obstruction fairly commonly also. Next slide. And then incontinence, so the opposite. So, but also think about meds because that's going to be one of the really common ones. People that are on diuretics, but also things that they might be ingesting, like caffeine or alcohol, that all could impact their ability to need to urinate more frequently and not be able to get to the bathroom in time. Other things like alcohol, again, we get into things like the opioids, antipsychotics, muscle relaxants, even NSAIDs actually can contribute to incontinence. And then, thinking about stress versus urge incontinence, just kind of differentiating those. And I have some kind of links for some kind of like nursing algorithms and questions that can kind of help with that. But also the mnemonic of the diapers, where this is kind of a common causes of incontinence. You think about deliria or dementia, of course, infection, like we talked about, atonic bladder. So not having as good of that muscle contractions, instead of, holding on to the urine, having the sphincter that release it. Medications, diuretics, also just, we'll see this also psychologic. So depression or just a lack of will to get to places on time. Endocrine, diabetes, so that also can be a big factor. Reduced mobility, and then similarly to retention, you could also have stool impact contributing to that. Next slide. And then so just best practices for prevention. So sorry, my phone was going off. So these is just an example of some of the things like keeping the bag below the level. So things aren't, moving backwards into the bladder. Avoiding those kind of dependent drainage tube loops, not having it sit flat on the bed or dragging on the floor. And then needless, I think the next a couple slides down, and we talk about some of the sampling mechanisms, emptying it regularly. So all these things to kind of reduce the risk of infection that many of you all know too well in the long-term setting. Next slide. So these are some assessment tools. So this is the one on the right is an ASAP, is from Nebraska, where they have this ASAP. They have all these great policies. And this is kind of like an S bar, and like also a communication. It gives tips on like how to communicate and stuff like that. This is something that you can adapt to your or edit to your institution. And then the one on the left is from HRQ. And so this is kind of a series of readiness to address, like if this is an issue in your facility, if you notice a lot of asymptomatic bacteria getting treated or a lot of unnecessary urine sampling, this will go through, this is kind of like a spreadsheet, an Excel sheet, and it'll give you kind of a score and kind of give you next steps on how to address these in the facility. Next slide. And then, so this is another HRQ. So this is actually, so this was a study. They called this in a long-term care, they called it a technical bundle. So it was a combo. It was kind of a combination of removing catheters, having kind of nurse-driven algorithms on getting these out, identifying like COTI champions, and then they would do these regular assessments and they would train on catheter care, and kind of also focusing on incontinence care planning. And so, and additionally, they focused on hydration and nursing in the nursing home residents. And so, doing kind of this technical bundle that they called it, it actually reduced COTIs. And this was multi-state, and I feel like there was 100 nursing homes or something. So they actually found a 54% reduction in COTIs, but also as that leads up to that, they found 15% decrease in urine culture ordering. So next slide. And that's a citation if you want to look at that. That was a really interesting study. I think there was no Kansas, I think Colorado participated in it though. And then also this is from that Public Health Ontario that I mentioned. They just have some really awesome resources. They focus a lot on UTIs in nursing homes. And so this is the toolkit that I was mentioning earlier. They have so many different like check, things to check on your facility, the readiness, the buy-in, barriers to change, really just awesome resources if you want to check that out. Next slide. So moving on to kind of what we were talking about, the sampling. So we think about some of the catheter bugs are a little bit different than we have for our normal UTIs. And that's because, with the catheter, they don't need those types of virulence factors that you might have for the regular UTI. They don't have to adhere to the epithelium as tightly because you have that catheter there. So you might start seeing a little bit different, a shift in the type of bacteria. So for example, Candida is really almost never going to be causing a urinary tract infection with someone that has a normal bladder. But you have that catheter, that kind of conduit, that makes it more common to then cause an infection there. Next slide. And the reason is this. So it's the biofilm ability. So a lot of those bacteria, they're going to form this slime layer, this glycocalyx, basically. They get that on the catheter, and then the bacteria get within that. They communicate within that, and then they survive on that. It's like a protective layer from antibiotics also. And so until you get rid of that slime layer, wherever it's adhered to, you're just going to keep having those bacteria over and over again. So you could have this if you don't change the catheter with an infection. So say they have an infection, they have this bacteria sitting in this slime layer, you treat them for infection, but you didn't remove the catheter, stop the antibiotics. Likely that those bacteria, if they were causing infection, that then start to grow again, and then they can cause another infection right away. So this is part of the issue with why people are so prone to UTIs with those catheters, but it's also really an important part of our management too, to make sure that we exchange those for a fresh one. Next slide. And so what you get into is you'll get these samples from catheters, and you might be not getting, like, it might not be reflecting what's really in their bladder. You might be getting urine that is being sampled because it's sampling what's in that tubing, in that slime layer. And so this is the reason why when you get multiple of those bugs, so you're getting E. coli, you're getting Klebsiella, you're getting all these bacteria, or it's saying normal flora, what you're really catching is that biofilm bacteria. You're not catching like true bacteria that's causing infection. And so this is why it's helpful to have like this, either to get a straight, so remove the catheter, get a straight cath. That's the best sample, but really using those needleless sites are helpful to kind of minimize, hopefully, that where you're culturing that biofilm. Next slide. And then this is our state antibiogram. So I'm actually going to update it this year, but this, I just pulled the kind of common urinary pathogens. So you can kind of see here, really for our most common UTI bug, E. coli, nitrofurantoin or macrobid, that still has a susceptibility of 96%. And then you can actually see cephalexin or Keflex, 86%. So still, so pretty good coverage for those really common antibiotics. If you want to go to the next slide, which is what the guidelines are actually adapted to, is really that E. coli. It's most common. So nitrofurantoin, macrobid, pretty much that's going to be the preferred agent for UTI. But this is something where you can have these and adapt them to your facility. If you tend to have E. coli that is resistant to macrobid or nitrofurantoin in your facility, then that would be not your top line choice. But generally speaking, it still is retaining very good coverage for most E. coli. Then you can kind of just see here the alternatives and stuff. And this is something I'm not necessarily going to go over, but I think it's just something that you can build, or you can adapt it to your facility. Next slide. And then the citations are there, of course, so this is based on kind of our national guidelines. And then here's some options for more resistant bacteria, including VRE and ESBL, if you want to incorporate something like that into the guidelines. Next slide. So moving on to the initiatives. So this is just to go over that. Really, if you want to change it, you have to really target the system and then not just the people. So a lot of times we'll focus on education, just trying to make sure people are aware of asymptomatic bacteria, minimizing urine culturing. But really, the most efficient and sustained initiatives are going to be when you target both of those, and really just focusing on one thing at a time, not getting kind of overzealous and trying to change everything, but trying to make one change at a time and make sure those things are kind of complementary. If you want to go to the next slide. And this is so a big thing is urine culture stewardship. So really focusing on making sure that we're improving our sampling techniques. So you get into the pre-analytic phase. So this is before you even get the culture, before you even decide to get the urinalysis. Think, does this person really having symptoms, or did they fall because they had an increased diuretic or they had an increased beta blocker or whatever? There's an alternative cause. Don't even go down that. So that's that. Before you even get the sample, you won't have to think about it downstream if you stop it at that point. Other important factors about thinking about um, really important ways to collect that, and making sure it gets sent to lab at a timely, because the longer it's sitting out, the more you're going to start having things grow in it. So there's also kind of, making sure that gets to the lab in the appropriate time. And then also the culturing criteria. So we decided to get the urinalysis, and now thinking about how are we really reflecting on the results of this. And then also there's the post analytics. So you got the urine sample, you got the results, now thinking about what to do with that. So we'll kind of go over this. Next slide. So this was a multiple studies where they looked at reflexing of the urine culture. So say this urine culture, this urinalysis did not have a set criteria of say it had less than 10 white blood cells in it, and so they would stop there. They would not proceed to getting the culture. And so this was a combo of several studies. It was a meta-analysis, and they actually, you can see here the outcomes of that reflex urine culture algorithm reduce the amount of urine culture results by nearly half. So this is something that you can engage with your lab to work on. Next slide. And then you can see similarly, this was actually an inpatient, so acute care and long-term, but you can see how it really, over the course of a year, was significant cost savings by having this. This was just one study, so not the multiple studies as the prior slide, but saved the lab a lot by having this reflex culturing. Also, I will note though that they actually didn't find a change in their CODI rates in this. But they did similarly find like almost a half, reduced it by a half as the amount of cultures. Next slide. If you think about doing this, you have to you have to think about what criteria you want to have as your reflex cultures, and also have the ability to opt out. So you don't want to restrict this to certain populations where say a neutropenic patient that's not going to mount that white blood cell response. So really thinking with your medical director and figuring out, if you do want to go down this, figuring out the criteria that you have for this type of reflexing. Next slide. Poll question number 4. So which of the following are examples of clinical decision support systems? So is it an order set for CODI, a best practice alert that is triggered when you might put in a diagnosis of UTI? Is it an EMR pop-up of a relevant UTI variable, such as you put urinalysis, it'll choose you down this algorithm? Or is it all of the above? Are those all clinical decision support systems?
Still have a few answers coming in. Okay, it looks like it's slowed down, so I'm going to go ahead and end the poll.
Perfect. All of those are the above. Yes, those are all examples. Next slide, please. And so this is an example of kind of what you might see on the electronic record. So something, I mean, this is vast. So there's so many different options as you guys answered on the previous slide. But this would just be an example of kind of one where, and also giving the clinicians the ability to opt out is important. So I'm going to kind of go through quickly because I want to make sure to get to STDs. Next slide. Next slide. This is just another example of kind of something that might look like concern or a different type of EMR. So this is a meta-analysis where they looked at multiple studies with clinical decision on the urine culturing. And so you can see how impactful it can be on reducing particular types of antibiotics and improving more guideline adherent antibiotics, improving stuff like macrobid or nitrofurantoin and reducing like our fluoroquinolone use. Next slide. And then this is again meta-analysis. So this is reducing NCOTI rates by using those decision support systems. Things that don't have to be as complex, things like order sets, or even like decision support, which I'll show you an example towards the end. Next slide. I'm going to go through this very quickly. Again, I want to get to the STDs in the last 15 minutes. But another thing that you can do is work with your micro in giving nudges. So you put a comment in the results and that will nudge them towards a certain decision. So it'll give some information about that result. Next slide. So this would be an example of like adding a text description of multiple organisms present indicating likely contamination, or another comment might be no pyuria, culture not performed. So things that can stop there. Next slide. And then this is an example of a Candida nudge that actually this is in St. Luke's here in Kansas City. So they found that by putting this nudge around, Candida is generally not considered normal flora. Well, it's kind of a lengthy comment actually, but anyway, it did result in reducing their antifungal use by about 14% for Candida in the urine culture results. Next slide. And more importantly, you can keep going, Loretta, next slide, but it didn't impact their long-term outcomes. There was no increase in fungemia. So communication strategies. So one of the most important factors in deciding to prescribe antibiotics or not is this action bias. So we have this sense where we want to do something. We don't want to just say, you had a negative result and stop it there. You want to provide some guidance for that person. Next slide. So these are some examples of how you can reframe the message to address that action bias and give a next step. So these are prescriber kind of examples where instead of just saying watch and wait or cultures are negative, you can say this is what we're going to do. We're going to start this pain relief. We're going to start the azo, or we're going to increase hydration, etc. So you give them next steps to do. Next slide. And then this would be an example of nurse. How do you communicate that back and forth instead of just saying, like, this is not a UTI, you stop there. You give them the next step. So they could document in the chart, given symptoms inconsistent with UTI, they have smelly urine, but there's no this. And so that's where you can kind of have that confidence to stop there. Next slide. And then the pharmacist too, some kind of examples of how you go into that action bias. So you give on the communication back to the physician, maybe reminding them that the guideline says this, we've been having issues with C. diff in the facility. Would you mind if we reduce the duration from 7 days to 3 days or 5 days or whatever? Next slide. And then this was the decision support where I mentioned where we created these, where it kind of just gives different alternatives for treatment and symptom relief. And it gives guidance for them if they're having, like it gives down here the diet or hygienic stuff, more information. I use these in clinics and they're very helpful. And so I'll send these out. I'll send these to Loretta with the examples of how you print these out and basically just like a regular script pad. And then it gives them information on like what to call back if, or return if they're having persistent symptoms. And then it also gives them their diagnosis. So pelvic floor dysfunction, asymptomatic bacteria. So they have more information on that. Next slide. And then this is, so many of you know Rob Geist at KDHE. This is his interactive HAI spreadsheet that he done. It's so helpful. And so you can actually download this. And so this has where you can track your UTIs, your CAF use, CODIs, other things like C. diff. So really great resource there. Next slide. And then this is just kind of examples of how to feed that information back to the workers. Next slide. So I'm trying to get to the STDs. So, so this is a graph from CDC. You can see here the rate of increase in our older population. So in the red, the men aged 50 to 64. This is syphilis in older adults. Look at that. Look at that rate of increase. So really, we're not just experiencing syphilis and other STD increases in the younger population, but it is across the board. And this was a study where they actually looked at, I think this was, New England Journal. This was about a little over a decade, 15 years ago. And they asked these certain types of age groups how much they were sexually active. And you can see that actually people that were age 57 to 64, 3/4 of those said that they were sexually active. And so the oldest group, 75 to 85, still a quarter were sexually active. And then you get here down here, even like the red dot is the poor or fair health. Even 20% of the 80 to 80 or 81 to 85 is reporting that they are sexually active. So just, with the new, with, you're not menstruating, there's lower risk of pregnancy, well, no risk of pregnancy, probably, the erectile dysfunction treatment. So that might all be playing into these increased rates of STDs across the board, and especially in older populations. Next slide. And then I think the next one's a final poll question. So this is kind of a trick question. Which of the following age groups accounted for the most cases of early syphilis in 2020 in Kansas? I think, I meant to say in Kansas. 15 to 19, age group 15 to 19, 20 to 24, 25 to 29, 30 to 34, 35 to 39, or over 40. So in Kansas, what age group had the most cases?
I have a few answers kind of rolling in, but it is slowing down. So I am going to go ahead and end the poll.
So over 40 is actually the most cases of syphilis. So this is a graph from 2020. And so you can see here, this is not rate. So when it is, Phil took out my graph of rate, but when I did put a graph in rate, so it is definitely not the highest in the over 40, but the absolute amount of cases are in those that are over 40 in Kansas in our last epi years. Next slide. And then this is just kind of a graph of the last, I think there is one updated graph, but this is the most from the CDC. Kind of see here county level, the highest rates of this is syphilis. And you can see how really concurrent with also the older population, but really across the board, the rates of syphilis have really been going up the past decade. Next slide. And then these are some pictures, just kind of primary. So primary syphilis is right when you get the infection, incubates around 2 to 3 weeks, and then you have a short course of that infection. So anywhere that syphilis really originated, whether it be the mouth, the genital areas, that's where you're going to mainly have that symptom. So you're going to have this painless ulcer. It's called a chancre. You can also have some lymph nodes can swell, maybe might have a little bit of symptoms. This generally goes away. So that's the primary episode. Most people don't recognize when they have that. Most people get diagnosed more in the secondary stage when they have this rash. So they classically we think of it being on the hands and soles, but really most of the cases I see it's kind of anywhere rash. And it can look like a lot of things. So it's the great masquerader is syphilis. You also, these are some pictures of kind of this patchy hair loss, this alopecia here, that sometimes can happen. And then you can kind of see some just abnormal mucosal lesions, like as an example in this one. Tertiary is when it's been there for a long time. It starts to affect the CNS or the cardiac. So people might have problems with dementia, memory. They might have headaches. They might have hearing or vision loss. And rarely in this day and age do we have cardiac involvement, but it can happen where they might have aortic involvement. They might get aneurysms or this inflammation of the vessels, arteritis, things like that. Again, super rare for that. Mostly it does tend to be the neurologic sequelae though. Next slide. And then this is so you can get these a couple different. This is the traditional algorithm where you get the RPR, but you can also get this kind of reverse sequence where you get the syphilis antibody. That's the immunoassay. So either way of those, you can check depending on kind of how prevalent syphilis is in your population. Both are acceptable ways to do the diagnosis. And then it'll reflex to the next test, which again, if you got an RPR, it reflects to the syphilis, to the TPPA. And if both those are positive, you have it confirmed, versus is a little bit different on the reverse algorithm. But regardless, once you get to the diagnosis, if you have if you have the primary, the initial ulcer plus that, or the secondary where they have kind of the rash, or it's really been acquired in the past 12 months, you can treat them as primary syphilis or with just one penicillin, bicillin. If you're talking about latent, meaning you don't know how long they had it, they could have had it 2 months, they could have had it 20 years. You don't really know. This is the first time that they've ever been diagnosed, and you have no prior testing and they have no symptoms to kind of guide you what they had. Or if you have those tertiary symptoms, that's when you get into the 3 weeks of the penicillin. If they have neurosyphilis, that actually is an IV penicillin course. And that definitely would be something you could refer to infectious disease for. Next slide. We were going to go on to really the most common STD, and you can see here the rates of chlamydia. Again, this is the older age groups where it's really skyrocketing. And really in men, like so many people can be asymptomatic, anywhere from 40 to this. There was some percentage out of the CDC that said up to 90%, 96% are asymptomatic. But if they do have symptoms, they might mimic a UTI. They might have burning, they might have discharge, they might have pelvic pain. But also if they did have exposure in the throat or the rectum, then they could have proctitis, they could have pharyngitis, they could have sore throat, etc. Next slide. And then this is where you get the diagnosis for this is a PCR. So really urine PCR is kind of your cornerstone of diagnosis. But if there was a concern of sore throat exposure, oral sex exposure, rectal, then you could just do a PCR of that region too. Treatment, so the treatment preferred is doxycycline for 7 days. And depending if you have, like if it was involving the rectum or the epididymitis, it could just be a little bit different duration. But generally, doxycycline is going to be your go-to for that. Next slide. And the last but not least STD that we're going to talk about is gonorrhea. So chlamydia is more common. It is escalating a lot more, but you can also see the gonorrhea rates are really going up a lot. The symptoms are going to be pretty similar for gonorrhea and chlamydia. And you could still have that sore throat. You could still have pharyngitis. You could have also conjunctivitis too if it got in the eyes. A little bit less common, but still a very common STI. Next slide. And the same way you diagnose, so it's a combo test. So it's gonorrhea plus chlamydia is in that urine PCR or the throat PCR or the rectal PCR swab. And so that is, so you're going to get those for both of those. And then the preferred treatment for gonorrhea is the ceftriaxone, which is IM. Next slide. I think that's actually the last slide. Oh, taking a sexual history. So there is a really good example of this on this link, actually. So it's the 5 Ps is the way to take the sexual history. And so that's partners. Who are they sexually active with? When was the last time? What are the gender practices? What type of sex? Is it oral sex, vaginal sex, rectal, or anal? Is it, and are they using condoms for the 3rd P? And then past STI is the 4th P, and then pregnancy, which might not be as applicable in the long term, or it might be applicable in the long term population. Next slide. So if you want more information on kind of that, how to do a sexual history, that there's this really short kind of podcast. It goes through all, like, many different types of exam and how to ask the right questions. I got through that. I was worried I might not get through the STD one, but I did indeed. Any questions?
If you have any questions, feel free to unmute yourself, or you can place them into the chat as well. I did receive one question by email this morning, actually, so I'm going to go ahead and ask that. She asked if there was where to find information on how often should a catheter be changed.
So yes, so I know there's a difference between the IPAC. Definitely the IPAC, I think, is not recommended to change it only once it gets crusted or obstructed, or for instance, if there's a UTI. So otherwise not replacing it. I did pose this question because that is in the CDC guideline, only when you're having issues with it. I checked with our urologist because generally speaking, in the acute care setting, in the hospital setting, what I've been used to is we tell people to change it out monthly or at every 6 weeks. And so that is what the urologist strongly recommended. And the reason being is that I guess it's this crusting issue. So they'll really start getting clogged up and crusted by about that 4 to 6 week mark. So that, generally speaking, is when I would say clinicians recommend us to change it out. If you don't have crusting by 4 or 6 weeks, then you can extend it and not need to exchange it that frequently. But that's from the more management side. From the IPAC side, just know that the CDC says only once you're having issues with it or infection.
Thank you.
And the IPAC people, IPs, you can answer that question way better than I can.
Mm-hmm.
If you have any other insights, feel free.
Well, I am not seeing any questions in the chat. Is there anyone that would like to unmute and ask a question?
And I will say, I like to put like links and resources. And I think, Loretta, you were going to send out the slides and stuff, weren't you?
Yes, I will send out the slides with a recording link as well.
Perfect. I just saw a few questions about if the
Yep.
resources were there. So.
Okay, well, if there aren't any other questions, I'll just kind of close up with a little bit of information. So thanks again for that wonderful presentation. And thanks everyone for joining us. Upon ending the webinar, the evaluation should appear if it works as I planned. So we shall see. But please do take the couple of minutes just to provide your feedback real quick. And just as a reminder, next month's is about initiatives for wounds, skin, and soft tissue infections. So if you can, please join us on July 20th at 1:30 for that. I likely will be not on that webinar. Nadine will be running it as I will be doing a Project First Line session that day. So thank you once again for joining us today. I'm going to go ahead and end our session today.